Good morning and welcome to the Maryland Colorectal Cancer Task Force webinar on organizational and personal health literacy. Claire, go ahead and advance the slide.
Yeah. Cool.
Before we get started, if you could perhaps add your name and organization or institute into the chat, we'd appreciate your participation. And as you do so, we'd like to go over a few housekeeping items as well. This session will be recorded and posted on the Maryland Department of Health website in the coming weeks. Lines will be muted during the presentation until the Q&A portion of our webinar. Please send all questions through the chat feature, and we encourage you to do so throughout the discussion. We will again open those lines towards the end of the presentation for live conversation as well. And a post-event survey will be added in the chat, as well as a follow-up email at the completion of today's presentation. The presentation will also include the recorded session, as well as the slide deck and resources. When having conversations today, please remember, do not share any personal information about a patient. Next, please. For reference, the American Cancer Society, the Maryland Colorectal Cancer Task Force is a state-based volunteer-led effort designed to reduce colorectal cancer incidence and mortality burden within the state by achieving at least 80% colorectal cancer screening. Through our task force efforts, our overarching priority is to convene audiences of leaders in Maryland to set goals, objectives, and implement strategies to increase colorectal cancer screenings in Maryland. What you see before you is just a few of our organizations that are currently represented in our task force. Next slide, please. In Maryland, according to the latest BRFSS data, Maryland currently sits at 73% screening rate. But as you look deeper by race, ethnicity, gender, insurance status, and zip codes, you will see the screening rates are not equitable. Next slide, please. On to today's speaker. Today I present to you Dr. Cynthia Bauer, who is with the University of Maryland School of Public Health. She's the endowed chair and director at the Horowitz Center for Health Literacy. She is a health literacy and health communication expert focused on improving health literacy at the individual, family, community, and organizational levels. She is a professor at the Department of Behavioral Health and Community Health and the principal investigator on multiple projects on health literacy techniques for clear communication, digital health, diabetes, and organizational improvement. Dr. Bauer, thank you for your time today, and we now present your information. Thank you.
Great. Thank you so much, Kathleen. And I'm very pleased to be here with you all today. I'm pleased that you're interested in hearing about personal and health and organizational health literacy and to see the turnout today. So I hope this can be a little bit of a conversation and that we can get to your comments and questions. I don't have an overwhelming number of slides. That's one of the things that you learn when you're doing communication and health literacy work, that you have to practice what you preach. So I try not to have too many overwhelming slides when I do these kinds of talks. So I think, think about your comments or questions. I expect that the organizational health literacy piece of this will probably be the newest to many of you. So happy to talk about that and answer questions. So just to follow up a little bit on what Kathleen said, we are a center focused on health literacy. We are the only center for health literacy in a school of public health. And we do a lot, not just within the school and the university, but also within Maryland and across the country. So very happy to have any follow-up conversations with any of you who are interested in learning more about what we do at the Center for Health Literacy. Next slide. Next slide. So we have 3 learning objectives today. First, to get a handle on what personal and organizational health literacy are, to talk about 3 factors that affect cancer screening, communication, decisions, and processes, and then to talk about 3 best practices that organizations can do to enhance their cancer screening. Next slide. So I want to situate our conversation today in healthy people. So I started my career in public health working on the health communication objectives in Healthy People 2010. And health literacy has really evolved over the last 20 some odd years. Health literacy kind of came into the medical literature once physicians started looking at the adult literacy data that was coming out of national surveys from the U.S. Department of Education. And in particular, the 1993 data really caught people's attention. And so that was very much focused on individual level literacy and numeracy skills. So in Healthy People 2010, those first health literacy and health communication objectives we had were based on data that we were collecting from individuals who were responding to questions in this national study about literacy and numeracy skills. And again, this was done from an educational perspective, not from a health perspective. And it was only when the Department of Education repeated that in 2003 and reported the data in 2006 that we have, to date, our only national population level data on adult health literacy skills. And at the time, back when the data were collected in 2003, there were only 12% of the adult English-speaking population that had proficient health literacy skills. So people's responses were recorded and organized along a dimension of below basic, basic, intermediate, and proficient. And only 12% scored in the proficient category. So that also was a real wake-up call for people because the materials that people were being asked to read and respond to were not complicated. In the proficient category were, health insurance information and, similar kinds of things that we know everybody has to be able to use to navigate our healthcare system. So the focus started to shift towards thinking about what organizations and health professionals could do. If this was such a widespread problem that we really only had 12% of our adult population that could deal with, really very routine health and healthcare tasks, this was a much bigger problem than I think a lot of people really had thought at the time. And so the focus gradually has been shifting and now is very firmly in Healthy People 2030, focused on what health, public health, healthcare organizations, health professionals can do to change people's experience with health information and health communication. Because the reality is that adult literacy skills change very little over time. They can be coached to use their literacy skills sort of more productively or more effectively, but you can't fundamentally change people's literacy skills in, very large ways on a large scale. And so we have to deal with where people are, right? We have to invoke that public health principle of meeting people where they are. And if adults' literacy and numeracy and technology skills are less than what is required to navigate our healthcare system, then this means we've got to look at the way our healthcare system is organized. And so that's really where Healthy People 2030 has landed and led to splitting the health literacy definition into 2, into personal health literacy and organizational health literacy. However, what that has meant in Healthy People terms is it became what's called a developmental objective because there is no national effort to measure and report health literacy on either dimension, either from a personal perspective or an organizational perspective. So next slide. So the definition for personal health literacy is very much reflects that history that I just recounted. So if you look at the definition that came out in the late 90s and then was used in Healthy People 2010 and then in 2020, it's very similar to this definition. I wanted to call out a couple of key things, though, that have changed. very much a focus on use. So finding and understanding information has always been part of personal health literacy, but how people use that information for health-related decisions and actions, not only for themselves, but for others, right? Recognizing that very important role of caregivers, family members, friends, other people who are in our universe of health decision-making are now part of the definition. So that was not in the original health literacy definitions for 2010 and 2020. But otherwise, the definition is quite similar. It goes obviously beyond people's ability to read or write or to do calculations. It's the full spectrum of being able to locate the information that's relevant to you, to comprehend it, and then apply it to the situations at hand. So it's all of those pieces combined to make personal health literacy. Next slide. Oops, there should be one before that. No? Okay, well, we'll go to the, okay, go ahead. So the reality is that anyone can have low health literacy. The tendency oftentimes is to associate low health literacy with other social determinants or other demographic factors. But the reality is that health literacy is very contextual. And I usually recount stories of my own experiences being in low health literacy situations, right, where the demands are either so huge or I'm new to a situation or the volume of information is just overwhelming, that it's not a matter of my education level or my actual literacy skills if I were to take a test, but it's really about that contextual situation in terms of how I'm being asked to use and apply my my skills and my knowledge. And in the Center for Health Literacy, we focus a lot on primary and secondary prevention, which I know you do as well as a member of a screening task force and looking to increase screening rates. And we focus a lot on the everyday health decisions. So not just those 2 or 3 times a year that somebody on average might be interacting with the healthcare system, but on those everyday health decisions when you're standing in the grocery store or you're trying to make time in your day for physical activity or you're trying to get a screening test scheduled. Those are the things that can be equally challenging to the more obvious ones of having a conversation with a healthcare provider or being given a diagnosis or having to take medications, right? All of those things are sort of the more obvious applications of personal health literacy. But personal health literacy is really a moment-by-moment condition that we all experience every day, and that's why anyone can have low health literacy. And for your next seminar, you'll be hearing from one of my former federal colleagues. When I worked at CDC, I worked very closely with Cindy Brock at the Agency for Healthcare Research and Quality, and she's going to be talking at your next seminar about many of the tools that they have developed. And AHRQ has really pushed this notion of universal precautions, which I know Cindy will talk about. Universal precautions means we recognize that everyone can be challenged by low health literacy if the circumstances are right. So next slide. So I said there were now 2 dimensions to health literacy. So this is the organizational piece. And this is where we come in as public health, healthcare professionals, social service professionals. I know you come from a range of organizations. But this organizational piece is what we do in our professional capacity to make sure that people can do those activities I outlined in the personal health literacy definition. So what are we doing as organizations to make sure people can equitably find, understand, and use information and services for themselves and others, right? So the equity piece is really important because, as I said, everybody can be challenged. Some people may be challenged more than others, depending on what the circumstances are or what the skills are that they're being called on to use. But we need to bring an equity lens to our understanding of health literacy practices. And so you'll see the definitions are very parallel, but the focus is on what we're doing to make sure people can get what they need, because we sit in a very enviable position, right? We manage the programs, the budgets, the resources that people are trying to access and use for those health-related decisions and actions for themselves and others. And so the responsibility is on us to make sure that people can do those activities. Next slide. So this should be familiar to all of you. It is the cancer continuum from NCI, and we're particularly interested in the prevention and detection columns at the moment because we're thinking about getting into some new work in that area. So I want to focus a little bit on that because I also know that it aligns with the interests of this group. But if you think for a moment, all of those micro tasks that I referenced when we were talking about personal health literacy, all of those day-to-day decisions that we make at the individual and family level, right, about using tobacco, about eating a healthy diet, about the amount of physical activity that we get, whether or not we use sunscreen and other sun protective measures, whether we're getting vaccinated, right, whether we're scheduling our screening tests and following through. All of those things have multiple steps to them, right? We have to form the idea that those things are even important and necessary to do. We have to be informed about what's involved in that action or decision. We have to make plans, right? We have to maybe gather some resources. We might need some new skills to do all of those things. We might need to consult with others. Maybe we have to access healthcare services. Maybe these are things that we do on our own. But you can see that health literacy enters in on many levels and at many points during people's day. And so it really becomes, a pivot point for thinking about all the other healthcare related information and services that kind of cascade from those micro decisions that people are making. And we know that there's unequal exposure even to accurate and reliable information, right? Because of COVID-19, there's been this big focus on what, WHO labeled the infodemic, but really, COVID just made that obvious, right? Those of us who've been working in health communication information for a while know that we cannot count on people knowing about and accessing accurate information. And sometimes we even have a problem with health professionals, making sure that they're staying up to date and relaying accurate information to patients and family members and even with their colleagues. So accurate information should not be taken for granted, right? There's still a lot of work we have to do in terms of thinking about those basics about how people find and evaluate information before that cascade of other activities that I talked about. And you'll see that in the cancer continuum, communications is a cross-cutting area, right, across all the stages of the continuum. So next slide. So I want to introduce you to a notion that I know Cindy Brock will follow up on even more when she talks about AHRQ's resources. But this was a concept that developed a number of years ago in this turn towards organizational health literacy. So some of you may be familiar with the National Culturally and Linguistically Appropriate Services Standards. And those standards are designed to help organizations think about the steps that they can take to provide language access, language services, to provide culturally appropriate and responsive services. And these 10 attributes of a health literate healthcare organization are very analogous to that. There's many points of crossover with those national CLAS standards. So if you're familiar with the CLAS standards, you'll know that in version 2.0, they also integrated the health literacy concept into CLAS. And the 10 attributes also reference language access and culturally appropriate services as well. So there's a lot of points of intersection between health literacy and the CLAS standards. But the notion is that there's sort of 10 categories or buckets of, characteristics and activities. It's really a mix of things. So, for example, leadership is one of them, right? That you have the leaders within an organization recognize the importance of addressing health literacy, are committed to it, and they designate people within the organization to lead health literacy activities, right? So that leadership is actually the very first attribute in the list of 10. But there are other things about organizational practices, for example, about the way the organization creates health materials. And health materials is broadly understood. It could be your fact sheets, it could be your web page, it could be your social media posts, any type of information that you're putting out to the public. I referenced that there's, part of the attributes is making sure that information is available in all the appropriate languages and is culturally appropriate in terms of the concepts and terms that are used. So there's a wide range of things that are covered by these 10 attributes that I would encourage you to take a closer look at, because you could use it as a checklist. You could use it as the starting point for conversations, for brown bags, for in-services. There's a whole range of things that you could do just with this simple list of 10 attributes that could cascade into other changes that you might consider in your organization. Next slide. So here's the CLAS standard that I referenced. That principal standard then references health literacy being part of the principal standards in the ways that the CLAS standards advance health equity and improve quality and eliminate healthcare disparities. So health literacy is a social determinant. If you look at Healthy People 2020, both literacy and health literacy are called out as a social determinant. And health literacy and information access are a matter of equity. Oftentimes, communication sort of takes a back seat to other health equity issues. But if you think about it, we know, for example, that educational resources are not equitably distributed in our society. So it's not surprising that information is not equitably distributed. And we saw this again during COVID. It really made visible that, we were under the illusion that just because people were walking around with smartphones that we no longer had a digital divide. But we saw that broadband access, Wi-Fi access to something other than smartphones, for example, you'd actually do need a laptop to do some online activities. That we still have some real challenges in terms of information access. And so I think it's really powerful to have both the 10 attributes and the CLAS standards working together to draw attention to the health equity issues. Next slide. So I said that we were going to talk about some 3 practices that you could begin thinking about from this organizational perspective. These come from a 2017 article in which a interprofessional team they had taken a 2-step process. They had looked across all the health professional disciplines, so clinical and public health, had looked at what were the consensus practices, and then come up with a list of practices these are the top 3 of a list of 8. And so if you're looking for things that are that proverbial low-hanging fruit or quick win, these are the 3 that I would recommend. And one, of course, is to tackle the problem of jargon in our organizations. We all go through years and years of training. We become degreed or credentialed in different areas, and we start to adopt a vocabulary, a way of thinking and organizing information that really removes us and creates a gap between us and the people we're often trying to serve. And so plain language is a set of techniques. Part of it is changing out our specialty language, the words that we use that we've learned through our training and education. But part of it is a broader set of techniques to really think about delivering information in a simple, not a simplistic, but in a simple way that makes it as widely accessible as possible. So plain language is really an accessibility technique. It allows us to communicate with as many people as we possibly can when we use plain language techniques. And on the last slide, which I'm guessing you will all have access to, is a pointer to the federal plain language guidelines. There's a website, a federal website called plainlanguage.gov. There's a lot of plain language resources there, and you can download the federal plain language guidelines. You can look at examples. You can learn about how plain language has been applied in a number of areas. So there is a very easy and free resource where you can quickly learn some basic things about plain language. CDC also has some plain language resources on its website. There's a microsite within cdc.gov. It's cdc.gov/health literacy, and there's a lot of plain language and health literacy resources there as well. So can we go back to the previous slide? Great. So teach back is the second technique that I'd like to alert you to. Some of you I know probably already know and use teach back, but teach back has become one of the primary ways for clinicians in particular, anybody who does direct patient or client services, to make sure that they are providing information in a way that is understandable and useful to the people they're communicating with. Teach back is not a test. It is not a way for us to get people just to repeat. It is a dialogue, right? So once we give some information or some directions or, offer a recommendation about something, teach back is a process by which we then check how effective we have been in communicating that in a way that the recipient can understand. So there are many videos online that you can watch. There's a toolkit called Always Use Teach Back that's listed on the next slide. So there are a number of resources in which you can learn about and try practicing teach back. You can also take training classes and things like that. So there are many, many ways for you to learn about and practice teach back, but that's definitely a top practice in terms of our responsibility to make sure that we're communicating in a way that people understand. And then the last thing is to change the way that we ask about questions. It's so common for us to ask, do you have any questions? The only way to answer that, of course, is yes or no. And we know a lot of times people just say no. They say no because they don't want to bother. They think they might be imposing. They don't want to look silly, right? How many people preface that by saying what they say was like, I know this might be like a dumb question, right? But the yes or no really doesn't leave people very many options. So one of the most important things you can do is really signal to people that you are prepared and open for questions. And by asking, what questions do you have, right? That signals to the person you're communicating with that you are open, you are ready. And even if you're doing this in a digital format, right, you can convey this notion that you're not just pushing information out and expecting passive recipients, but that you are there to engage in a dialogue. So if it's on your website, you can provide multiple mechanisms for people to get in touch with you, to provide feedback. If you're doing it through social media, you can make sure that you are monitoring your social media channels and being fully responsive to the comments and questions that people are posing there. So there's an openness to answering and responding to people's questions that is embodied in this very simple question of asking, what questions do you have? And really eliminating and never ever asking, do you have any questions, yes or no, right? That is going to be a dead end practice that's not going to get you very far in terms of really making sure that you've connected with the people that you're really trying to connect with. So as you've seen, we'll go to the last slide there that lists some resources. The federal plain language guidelines. I mentioned there's the Always Use Teach Back online module that's free. You can take it and anytime. And then I've already shown you that we have the 10 attributes and the CLAS standards that would allow you to begin this process of internal reflection, of thinking about how your overall organization is organized and responding to many of these challenges that I've outlined today. So with that, I want to conclude my formal remarks and see if there have been any comments or questions coming into the chat, or if people have things that they would like to ask now. So Kathleen?
Thank you so very much for your presentation today. And as always, it's great to learn some new traits and attributes when working with our communities. So what I'd like to do now is open up our discussion to attendees. If you have questions, I encourage you to either come off mute or to share them in the chat. You're welcome to share them amongst the attendees or directly with our panelists. We do have a question in terms of working with populations from around the world. In addition to what you shared, would you have any guidance or recommendations in terms with global communications in terms of health literacy?
Well, I think that's really where the health literacy and the CLAS standards can be very helpful to use together, because the CLAS standards are very clear about the use of, professional and trained interpreters and professional and trained translators for your materials. And of course, if you have the mechanism, like if you're a hospital and you have a patient and family advisory council, or if you're a clinical practice or social services or community-based organization, hopefully you have some other ways of getting feedback from the people that you're serving. But I think that's often the best way. So the things that I've presented to you today are things that we can do from this organizational perspective. But as a communication person, I will tell you that really the only way if you're getting through and connecting with people is to get that feedback, right? It's a dialogic process. In Communication 101, we, have this very basic model of sender and receiver and message, and then there's, other things going on. There's like noise and other things. But if, as a sender, I want to make sure my message is getting across to the receiver, the only way I know that for sure is what I was describing in the teach back, right? We have to engage in that dialogic process where the receiver is giving me, the sender, feedback about whether or not we're getting through. And I know that a lot of times having professional interpreters is, a financial challenge for organizations, right? They may not have those resources. But again, this is where the 10 attributes and the CLAS standards can be very helpful for starting that internal conversation to say, if we are truly a patient or community or client, whatever the core relationship is you have with the community or individuals, if you are truly committed to that, then you're going to start thinking about how the resources are used within your organization to make sure that people are being served in the way they need to be served. And if you speak English and they speak another language, then that's what you've got to deal with, right? That can't be a back burner issue. It has to be a front burner issue. It has to be something that moves to the top of the list. And you think about, well, how do we organize our information, our services to reflect the fact that that is the patient or client or community that we're working with. So I don't think there's any shortcut around that. I think it is a perennial issue that organizations have to deal with.
Great, wonderful, thank you. At this time, Claire is going to adjust our settings to take participants off mute. And then we also do have questions in our question box that she is going to share with us. So at this time, in addition to the questions that we have, should you wish to pose a question, the lines have been unmuted, and I believe that there is a hand raising feature as well. So Claire, if you're in a space to be able to read the questions, please do so at this time.
Yep, I can do that. Hi, everyone. It looks like we have a question from Patricia Laskin. And Patricia, I've sent you an unmute request as well if you wanted to speak. But right now, Dr. Bauer, her question is, could you tell us more about monitoring social media to answer questions? Any tips?
Patricia, could you say a little bit more about that? When you say, is it something beyond, when you say monitoring, are you thinking, is it something beyond, watching for people's, comments and the extent to which people are liking and sharing your information? Are you thinking about something else in terms of monitoring?
This is Patricia. Can you hear me?
Yes.
Okay, great. Because I've lost my screen. Well, I'm just wondering, like in an organization, who actually addresses and monitors the information that you might put out on, say, your Facebook page? Or is that something that's going to go through IT? Is that something that your health educator person is really going to be able to respond in pretty close to real time?
Yeah, I would prefer somebody more in like a health education, health communication, navigator, community health worker role, right? Because it's not really an IT function. It's not a technical matter. It's more understanding, using social media as a window into what people are thinking. Like, so for example, I don't know how many of you are users of online review services, but there's a big difference between the companies, for example, that are very carefully monitoring the comments that people post about their businesses and those that don't, right? Because we know that people oftentimes speak up about the things that they're most passionate about, good and bad, right? If they've had a good experience, they're, oftentimes very excited to share it. But if they've had a really bad experience, they're often very motivated to share that as well. And you can see the difference in organizations that are very carefully monitoring people's comments and feedback in terms of saying like, I'm very sorry, that's not who we are as a company, like, let us make it right kind of thing. And so that's what I'm thinking about, is that social media, whichever channels you're using, that's an insight into what people are thinking about, what they're concerned about, what kinds of questions they have. And it's not the only way that you should be gathering that kind of information, because again, not everybody's going to be using it, but it's just one way to gain that kind of insight.
Thank you.
All right, it looks like we have another question. Okay, I'm going to go ahead and try to unmute you as well. Do you have any?
Doesn't mean anything.
And if you're not asking a question, can you just mute yourself?
I'm not sure if it's for me, but I'm thinking.
Hi, Claire, I can't really hear you.
Oh.
Yep, we just have some attendees who are just mute yourself. Use the self-mute feature for now if you're not talking, but let me see, I can pull up the question for Pamela now. It's, do you have any tips on how to engage colleagues around this topic when everyone is so busy with direct patient care? The 10 are a great starting point, but I suspect I will have a different time getting our team on board, or team engaged, sorry.
Yeah, so I did not show it because sometimes showing videos in presentations can be challenging depending on the technology platforms and also just the amount of time. But I know a lot of people who still use an American Medical Association video that's, made probably at least 15 years ago now. I forget the exact date, but it's still available online. The longest version's about 20-something minutes, but there's many, many shorter versions that go between 3 and 5 minutes. And I think one of the most powerful things is for, especially for clinicians, is that, I mean, there's a number of things that clinicians will say to me. First of all, my patients don't have trouble understanding me, or I always use clear communication, or, that's really not that big of a deal, right? The most important thing is like for me to, be able to make the diagnosis and give the patient that information, they'll understand it. And I think watching those videos oftentimes is that light bulb moment for clinicians, because it's not their patients, and they're able to kind of be in that self-reflective stance because they can see like, wow, people really do have a hard time with things that I thought they understood. And there's examples in that video, for example, of a young mom trying to interpret directions on like a liquid Tylenol bottle, right? And her interpretation of how much she's supposed to give her young child is not according to the label. There's somebody who's talking about, there's an older woman who is actually taking 2 medications for the same thing, but doesn't realize it because she didn't understand what the medicines were for. And she's, her stance was, that's not my job to question the doctor. So, if the doctor gives me that script, I'm just going to take it. So there's a number of just really routine, everyday things that we know challenge people in health communication. And I think that video can be quite helpful if you really feel like, wow, people are not going to see why this is important. But, I started out by saying that within, the clinical space, though, a lot of the health literacy work started because clinicians started saying, like, we know we're not really getting through to our patients. Why is that, right? We see we think we're doing all this talking, all this recommending, all of this explaining, but we're just not connecting with our patients. And health literacy, at least in the clinical space, was kind of born out of that self-reflection about, if our patients aren't doing what we think they should be doing, why not, right? And I think that can be a very helpful internal starting place. And maybe just do it over lunch or over breakfast or something, or just a staff meeting. See if you can get that conversation going, because I think once people start reflecting on that, I don't think it takes them very long to kind of get to the place where, like, yeah, maybe we should be putting more attention on health literacy.
Thanks, Dr. Bauer. And there's just a clarification question. Is that, you said that was an AMA health literacy video?
Yes, I can send Kathleen the link. Like I said, there's many, many versions online. I think the original version is about 23 minutes or so. But yeah, I'm happy to send Kathleen a link to at least one or two of those.
That's great, thank you.
Thank you.
All right, and we have another question from Artie Varanasi, who Artie, I think, is one of our esteemed colorectal cancer task members. And she says, thank you for your excellent presentation and overview. My question goes back to your opening comments and the data that were collected in 2003 and published in 2006. Have there been any updates to the data since? And what is the current level of proficiency? 2003 was 12%, if I understood correctly.
That is right. Yes, and that was, as I said, that was actually done not from, U.S. Department of Health and Human Services. We did that in partnership. I was working at HHS at the time, and the connection, the liaison to U.S. Department of Education. But this was based on a household survey, and those of you engaged in research know household surveys are extremely expensive and time-consuming to do. And in the 2003 administration, we were fortunate that we were able to kind of piggyback on the general literacy and numeracy survey that education wanted to do anyway, because their motivation was to learn about the adult literacy programs that they fund across the country, right? So in each of our communities, there's some type of adult literacy and English as a second language service, network. And that's really what their motivation was, but they were also really interested in health because they knew that was a prime area for adults to apply their literacy skills, as well as it's a motivational thing. Like, if you talk to adult literacy teachers, their students are very motivated, their adult students, their adult learners are very motivated by using their literacy and numeracy skills in health contexts. So there's a lot of connection between the two, but the problem is that the Department of Education only does that study about every 10 or 12 years, and they made a different decision when they repeated it in 2012. They joined up with about 20-something other countries under the rubric of the Organization for Economic Cooperation and Development, and they did a cross-national study, and so they eliminated the health component when they repeated it. So you can go to the 2012 study data, but that's not health specific. It's going to be more general literacy and numeracy skill data. But the 2003 is still the only national population level health literacy specific. There's a separate report written by the Department of Education called the Health Literacy Skills of U.S. Adults. And that's still, to this day, the only data that we have, because nobody's been willing to invest in doing it again.
Wonderful. Claire, at this time, are there any further questions in the queue, or perhaps hands raised to ask a live question?
Let me see. It looks like we have one more from Catalina Billings. Catalina, let me try to find you and make sure you're unmuted real quick. Okay, just sent the request.
I went the roots will help it from eroding gas.
Oh, we're getting some feedback on our end.
Run it over.
Not sure who that is. Give me a second. I'm going to see if you're talking. Okay, so how, I guess I'm having a hard time translating it too. I apologize. But how can providers be
So what I'm
translating?
Sorry, what's the question?
sorry. Um, so I'm trying to ask how providers can be sure that the information, the health information, is transferred well to the patient if they are, having a patient of other language than English.
Well, it's really, again, through the combination of the plain language techniques, the professional interpreter, and the teach back. Because I used to work with the translation service when I worked at CDC. I worked a lot with the translation services there, and they would tell me that because of their professional code as translators, if they got information to translate that was written in very scientific or technical language filled with a lot of jargon, that's what even if they knew that they were translating something for a very different audience, they were still obligated to translate it with all of that jargon in it. They could give feedback to the person, the epidemiologist or whoever who had requested that, but they couldn't just on their own. So I think when you're thinking about oral communication, a provider communicating with a patient, really committing to using that everyday language is going to make it much easier for your interpreter to interpret that for someone else. And then that's going to hopefully set that virtuous cycle in process where your patient can then ask questions back. If they don't understand something, especially if you're using the teach back approach, then hopefully that's going to open up that opportunity. If you're asking, what questions do you have, then your patient will feel more comfortable asking if they don't understand. But I think it's really using all of those techniques together.
Thank you.
This has been a wonderful discussion today, and we are highly encouraged about the participation and the interest in the conversation that we've had around our first of 3 health literacy presentations. Claire, if you could advance the slides towards the end of our presentation. What I've done is included the post-event survey in the chat, as well as some of the resources that Dr. Bauer included, as well as what the task force referred to as well. All of these and more will be included in the post-event communication, but we also encourage you to reach out to us at the task force should you have any follow-up questions. Next slide, please. The next session will be on November the 4th, and we'll dive a little bit deeper into health literacy in terms of what we know works with tools, resources, and more, with 2 dynamic speakers set to speak on the topic. December brings us to our 3rd and final session on health literacy in terms of deeper conversations around cancer screening conversations, as well as 2 speakers from the regional area, as well as research that's being done from one of our American Cancer Society staff as well. So we encourage you to continue your participation on both of those offerings by registering if you haven't done so already. We also encourage you to share those with your colleagues. Next. My name again is Kathleen Connors-Juris, and I am one of 2 co-leads with our Maryland CRC task force. Please reach out to myself or Mary Joseph if you have any follow-up questions or would like to be part of our task force moving forward. With that, we thank you for your time today. We know that it's very precious, and we look forward to hearing more from you after the event. Take care and have a wonderful rest of the week. Thank you.
Thank you.